Okay. So, House of Lords had second reading before in September, and there's now been a committee formed, a small committee to take evidence on the subject. So the professional groups have been invited to present their views to this committee. Those views will be recorded. The committee won't express a view, we'll just simply record the evidence that's gathered. And then there will be a whole series of dates between now and Christmas and beyond. It's all on a Friday, because it's a private member's bill. Everybody meets on a Friday, which is a pain, I have to say, to be in London on a Friday. And it's probably going to go on and drift on till, I guess, towards Easter, before it's resolved. But anyway, Mark will tell us all about it from his point of view as a medic. Mark.
Thank you very much, Donald. And thank you very much, everyone, for inviting me. Can you hear me at the back? Is that okay? There's a bit of an echo in the room, so I'm aware that that can often make hearing a little more tricky. Thank you very much for the for inviting me. I hope this is going to be a helpful talk. There's going to be time for questions at the end. And so I'll just talk through what I'm going to go through. But really, in the time I've got, I'm only going to be able to scratch the surface of this issue. As Donald says, it's a very thorny issue, it's a very tricky issue, and it's a very emotional issue. And if I had to characterise the debate in the House of Commons, I know people were getting very excited about the fact that the House of Commons debate was done in a good spirit. But what I would say is that I don't think that it was done more on emotion than it was on evidence. And so I've recently been involved with a couple of co-conspirators, Colin Rees and Lily Lamb, and we just published an opinion piece saying, has the assisted dying debate killed evidence-based medicine? So we've put that kind of rather thorny thing out there just to really ruffle a few feathers. I'm from Scotland, as you can probably tell, just very soft accent. And I was born and brought up there. My mum is a Geordie, born in Heaton. My dad's dad was born, coincidentally, around the corner in Byker. But my mum's just done her genetics, and she is 65% Scottish, so that is a relief to me. I grew up in a Christian home. I'm one of 5 children. I'm the favourite child, but that's fine. I became a Christian when I was 11. I became a Christian through SU camps. My father used to work for Scripture Union, and I went to SU camps when I was 11. And when I was at school, I prayed that I would get some Christian friends, and then I invited 3 of my close friends to camp. They all became Christians, and we all recently went hill walking together for our 55th birthday. And so we're still good friends, and 2 of them are still going on with the Lord as well. My parents always taught me to ask questions, and so my father was very rigorous with faith and didn't just toe the party line, but he wanted me to wrestle with certain things. I graduated from Edinburgh in 1992. I know I don't look old enough, and I started doing palliative care in 1998 up in Aberdeen. And I did that following a period where I thought I was going to leave medicine. I was very experienced, I was nearly a consultant, and I was just really fed up with what I was doing. But then I started doing palliative care, and I felt a deep sense of calling that is what God wanted me to do. Throughout that time, I've done a lot of reading on assisted dying, and been part of the debate and done talks for the best part of 20 years. But we are coming to a focal point at the moment, as Donald has highlighted. And that focal point is a fairly crucial one. What I want to do today, though, is just talk a little bit about what the Bible says about this subject. Always the most important starting point. I'm going to talk a bit about my experience as a consultant and working in specialist palliative care for 25 years and dealing with dying patients every day of the week. And then I'm going to talk a little bit about some of the evidence and some of the things that are being discussed in the bill. But I'm not going to go into the bill in great depth, but that can maybe come out in the questions. So, what does the Bible tell us about life, and what does the Bible tell us about killing? Well, three things really that are important. We are created by God, in God's image, for God's glory. By God, in God's image, for God's glory. And in Genesis 1:31 it says, God saw all he had made and it was very good. This was on day 6 after he'd made a man, and he said it was very, very good. And the very important thing that tells us is that we have, and we are endowed with, intrinsic value and significance. Not by the basis of our abilities, or our brains, or anything, but because we are made by God and created for his pleasure. And as God's image bearers, we have a really great, deep dignity intrinsically. There is a little illustration I do with some of the students where I say, right, I've got a £10 note. I'm a Scotsman amongst Englishmen, so I'm not going to bring out a £10 note. But anyway, the illustration essentially is, you get a £10 note and you say, who wants this £10 note? And of course all the hands go up in the room. And then you scrumple it up. And then you say, who wants this £10 note? All the hands go up. And then you throw it on the floor and you stamp on it. And then you say, who wants this £10 note? And all, so you want this note even though it's broken, stamped on. Why do you want that £10 note? Because it has intrinsic value. And that little illustration is magnified thousands of times in the dignity that God has endowed man with, regardless of ability. So we are created by God, so we are under God's rule. We are created in God's image, and that's something that I know you will all know. The question is, what does that really mean? And it's worth just drilling down for a bit on that. So in Genesis 1:27 it says that humans are uniquely created in the image of God. So that means morally, we have an idea of what was right and wrong. And we also have an accountability. Spiritually, we're not just physical beings, we are spiritual beings. Mentally, we can use logic, reason, and learning. And some of the greatest scientists in the world ever are men of faith, men and women of faith, because they believed when they looked in a God of order that they would find order and reason. Relationally, relating to God and relating to others, community, family, and church. Relationally, we are made in the image of God. And physically, our 5 senses. One of the things I've meditated on over the years is those 5 senses. And the Bible talks about this a lot. That God sees, God hears, God feels, God tastes. And actually, we bear a lot of that too. All of those things. So we, in lots of different planes, if you like, are image bearers of God. And the Bible makes that very clear. And the last thing is that we are created for God's glory. Our lives are not our own. And that makes it different from the context of the current debate that is happening about assisted dying. It is my life. I can decide what I want to do with it. That is the antithesis of what the Bible says and the truth about God's order of things. What I will say is that the Bible also tells us that death is a curse, worth bearing in mind. So whatever I do in my job, I don't make death good. I might just make it a little less bad. But also death is not the end. Now these, if you like, the tectonic plates on which all of this stands, and we take these all for, wherever we stand in our faith, this is what the Bible puts as our foundational stuff. But what is the implication of these truths? Well, in Genesis 9:6, as you'll know, it says we must not murder. Whoever sheds the blood of man, by man shall his blood be shed. Why? For in the image of God has God made man. Again, we come back to that dignity and that value that we have. Also, more simply, in Exodus 20:13, it says, do not murder. Now, what about mercy killing or euthanasia? Does the Bible have anything to say about that? And if I had a bit more time, I'd probably quiz you to see what your Bible knowledge was about. But there are two interesting instances in the Bible of this. There is one in 1 Samuel where Saul is mortally wounded in battle, and he asks his armor-bearer to kill him so that he will not suffer at the hands of his enemies. He is asking the armor-bearer to kill him so that he does not suffer physically. Now, the armor-bearer does not do that in that story. The second one is Abimelech. I'm not going to press you on this one, but in Judges, Abimelech was raiding Thebes when a woman dropped a millstone on his head and cracked his skull. So he was dying. So again, he asked his armor-bearer to thrust his sword through him and kill him, so he could be spared the embarrassment or ignominy of being killed by a woman. And his armor-bearer did that. So he asked for it for psychological suffering, let's call it that. So one for physical, one for psychological suffering. But the key question is, how does the Bible view these things? Well, the truth is, it views neither in a positive sense. So when someone comes out of the woodwork and said that they actually killed Saul when he was mortally wounded, they themselves are put to death for killing God's anointed. So the fact that even it's a mercy killing, and Saul was going to die anyway, it is not looked on positively. And we, if you like, because we are made in the image of God and rescued in Christ, are God's anointed. Now, Abimelech's death is interesting because he was killed by his armor-bearer. But it is very much seen as a wicked end to a wicked reign and a wicked life. So it is in no way viewed positively. So those are the two instances in Scripture, neither of which you can argue strongly. And just to add a little footnote to that, whether it's for physical suffering or psychological suffering, consent from the person themselves is no defence. They both asked for it. So that just gives you a little bit to think about. But I still think the strongest argument, in my opinion, is the value God puts on us. That, for me, is the bedrock of all of this, the value of human. You matter because you are you, and you matter right up to the very moment of the end of your life. And my job in palliative care is to help people to not just to die well, but to live well before they die. That's my remit. So I'm just going to talk a little bit then, after looking a bit at the Bible, about how my 25 years in palliative care has shaped my thinking. And what I'm going to do is I'm probably going to correct some of the stories and narratives that are out there in the press that you may believe or not believe, but that just simply don't fit with my 25 years of experience. It has been my privilege over the last 25 years to work in the field of specialist palliative care. I've got an incredible team. They're absolutely brilliant. And we deal with some of the most complex and vulnerable patients you could think of. I can tell you stories that would make you weep, because people have given me the privilege of stepping into that situation. And I don't take that lightly. To be with people using the medical skills that I have learned to try and improve quality of life and help people live before they die. I deal with all sorts of illnesses, not just cancer. I have a specialist interest in neurological conditions, and I see a lot of those. And we deal from the age of 18 upwards. So we had a young girl who died with us. It's a lovely Christian family. She died following a heart transplant and complications from that, so she died with us in the hospice. So our average age is about 60 of my patients, so I see the span of ages, so it's not just for old people, the hospice. The other thing to say is the hospice, we only have 14 beds, but we have at any one time 200 patients on our books. So we have a community team, hospital team, community team during the day, a day unit. We have lots of different tentacles that reach out, because most of the work is out there. So my job involves particularly seeing people in the hospice, yes, seeing people in the hospital, so I go to the emergency department, I go to intensive care, I'm well known in both places to offer advice. I do the outpatient clinic and I see patients at home. And what we provide is, what Specialist Palliative Care provides is that complex specialist care for these patients. So that's about 15 to 20% of all deaths, roughly. But there's another 80% which don't need that complexity dealt with, but can be dealt with by either GPs, community teams, hospital teams, and all of those things. So part of my job is helping to support and train GPs and hospital teams to be able to deliver that less complex element. Does that make sense?
Yeah.
So I, in my head, always separates generalist palliative care from what I do, which is specialist. But I go a long way into that to help my colleagues come forward and learn. Does that make sense? Within the job, we deal with the holistic needs of families. So we deal with physical, social, psychological, spiritual. And we do get, and I do get requests to kill patients. That's not unusual. But what I would say is that when I start to deal with social, spiritual, psychological, physical issues, the number of these requests drops precipitously. They don't go away, but they drop precipitously. So, people change their minds. This is something you do not hear in the debate. People change their minds. And with the right care, many change their minds. And that's really important to bear in mind. There are two other things that I've learned which are really important. And it's a false narrative that everyone who is dying dies in agony, flailing around a bed in pain. That is a lie. Normal dying, which most of this society has been shielded from, is peaceful. Almost all the symptoms that are presenting can be controlled. But when was the last time you heard that on the news? We do have complicated pains, but we do have ways of dealing with it. We do have complicated agitation. I have not had, the most complicated deaths I've been involved in have been people who have had a degree of physical pain but have had psychological angst or existential issues about the meaning of what they're going through. That all mushes together, they don't talk about it, they don't deal with it, and you start to get this kind of heady mix of, that is remarkably rare. But it's my job to try and help unravel some of that. And my team. But even in complex death, peaceful death is the norm. If people get the right care. The second false narrative that's out there is that in palliative care we kill patients by using syringe drivers and morphine. That is simply not true. There's no evidence if you dose morphine properly. As with any drug, if you take 100 paracetamol, it's going to kill you. If you take 100 times the dose of morphine, it's going to kill you. If you dose these things properly, it improves quality of life. It doesn't actually shorten life. But I have to say to many families, I'm going to put up this pump because they can't swallow. I want to make sure they're going to get their drug levels the way they need them. I need to know that they're at a steady level. If they can't swallow, I don't want to compromise their pain control. So what I'm going to do is put an equivalent dose in a pump so that we can maintain control even when they can't swallow. Does that make sense? Mm-hmm. So that's what we're doing. And most people actually don't die with a syringe driver running. But because people die, a lot of people die with a syringe driver running, with this, you know what a syringe driver is?
Yeah.
Basically it's a machine that pushes in the syringe very, very slowly over 24 hours with a dosed medication inside it, under the skin. So it means you get steady drug levels, which means you get better control of the symptoms you're trying to control. But because people do die with that running, people think, oh well, they're dying, they've got that running, that must have killed them. What they don't say, which is 90% of people will die in bed. So they don't say, I'm not going to go to bed. They don't make the same link. Do you see the problem? So you've got to be really careful with the associations that are there. But there was no intention. The final thing I want to say in terms of my observations of being in this is that there is a lack of provision of palliative care, both generalist and specialist. There's no lack of will among medical professionals and nursing professionals, but there is a lack of resource. And we know this because 3 out of 4 hospices, and by that I mean the inpatient beds, are charitably funded, who only get 30 to 50% from the government. And that is actually a moral outrage. And even now, I'm having to have debates in the next week about how to cut our services. That's how serious this is. But we also know that provision of specialist palliative care is patchy around the country. We also know that the social care is patchy, psychological care is patchy, and psychiatric care is patchy. And it's in this context that we are having this debate. So we've talked about the biblical issues. I've given you some of my experience and kind of hopefully debunked some of the myths that are there. Now I just want to move on in the last little bit to talk to you about assisted dying. My juniors will tell you that I can talk about this for hours, so I've tried to keep it punchy. Okay? And hopefully some more stuff will come out in the questions. But I want to give you some facts about assisted dying, and I'm going to do this from looking around the world. And again, I want you to think, has this debate that you have been listening to been driven by emotion or by evidence? I'm going to give you some evidence, and I want you to think about, well, I didn't know that. Why did no one tell me that? And just to say that, why didn't the MPs know this? They did, because we wrote 450 letters to them. And the Lords knew this, because we wrote 700 letters to them with all of this evidence in, okay? So it is out there, and we spoke to a lot of MPs as well. In every jurisdiction where assisted dying has been introduced, the numbers have gone up. In every jurisdiction. Now, the reasons for that are actually quite important, but let me give you an idea. So in Canada, 1 in 20 people die at the hands of doctors now. 1 in 20. In Holland, it's about 1 in 25. But in some parts of Canada, it's 1 in 10. As soon as you introduce the idea, you cross a moral line saying it's okay to kill some patients. As soon as you've done that, it becomes much more difficult to then argue from that point that you can't move further forward. Because you change the moral framework, you end up in a position where actually death seems to be acceptable for some patients, therefore you move forward. Now, the other reason why the numbers are rising is because the criteria widen. A couple of examples. In Canada, they have moved from criteria of reasonably foreseeable death to non-reasonably foreseeable death. They have moved in Holland from a small number of patients getting this to 2005, disabled babies being allowed to be killed. Now, children are allowed to be killed. People with solely psychiatric illness to be killed. And they are having debates about if you're 70 and over and tired of life, you could be killed. I am told by the pro side that I am not allowed to invoke those countries because that's not what we're proposing in this country. That's not the kind of law we're proposing. That for me misses the point. So, in every jurisdiction the numbers are going up. The reasons for people asking, so I want to know, people are suffering, right? So that's my raison d'etre. People are suffering. I want to know, why are they asking for this? Why are they asking for this to be killed? And if you look at the evidence from both Canada, Oregon, which is the one that we're modelled on, the top 5 reasons, let's say, are it's loss of being able to get involved in meaningful activities, loss of dignity, loss of hope, fear of being a burden, or being a burden. And then number 5 is physical pain or fear of physical pain. So not even if you have physical pain, the fear of it. Even if you did believe this was a good thing, you've got to be honest about the reasons that people are asking for it. And if people are saying, I feel like a burden, I feel like my life's not worth living, I feel like I've lost dignity, what do you do with that? You find a way of addressing those issues. That's what you need to do. And up to 40% of people in Oregon say that they want to be killed because they feel like a burden. That is an indictment against society. 17% in Canada say that it's because of loneliness. This is more than just physical. People ask for psychosocial reasons, and that's why some of these horror stories are coming out of America and Canada about people who can't get the care they need, so they just go for euthanasia. They can't get their care financed, so they want to be killed. So, in Oregon, which is what's like being planned here, up to 10% of people said financial issues around treatments were the reasons that they wanted to be killed. Did you hear that in the debate anywhere? Because this is in the public domain. This is in the Oregon annual report for the reasons. So, it's widened in every place. Psychosocial reasons, not physical ones. As a doctor, if I'm going to introduce a new treatment, and I use that word loosely for killing patients, I would want to know what trials have been done, the best combination of drugs, and the complications. That makes sense, doesn't it? We do that with every other drug we use. You'd want to know the best drugs for doing it, the best combinations, which are the most efficient, and what the complications are. There is no peer-reviewed, and by that professional reviewing, peer-reviewed evidence in any jurisdiction that assisted dying, for assisted dying that supports the use of drugs for this purpose. Nowhere in the world. Oregon have used 5 different combinations in 27 years. If the law changes and I'm asked to do this, well, hold on a minute. Well, it's okay. Apparently the Secretary of State is going to tell me what I need to do or which device to use or what drugs to use. There's no evidence to tell me which is the best drug to use. I'd at least want to know, well, what are the complications if I give these drugs? So does it really achieve what we hope it's going to achieve, a better death? I can't answer that one either, sorry. Because there's no systematic data that's collected in Holland or Canada, and in Oregon, 62% of the data is missing. In the 38% of people where the data is present, 7 to 8% of those have complications. In the majority, we have no clue. So I don't know what the best drug is to use. I don't know the best combination of drugs to use. And I can't counsel my patients on what the complications might be. But just by way of information, in the 38% of people where they've found log complications, there are problems with ingestion because it's such a bitter mix of medication to take in high concentration. People have had seizures, so fits. Small numbers, but they've had them. And 9 people have woken up again. Three of those didn't come back for any more. And I can't find any information on the other 6 because that data is destroyed. Numbers have risen, psychosocial reasons are driving this, and there's no peer-reviewed evidence to tell me what the right thing is to do or what the right drugs are. Okay, but we want to do it because we want to help bereaved families. There is no evidence in accumulated data that this leads to a better outcome for bereaved families. So assisted dying across jurisdictions, there's no one-way leaning that tells you that you will have a better death or a better bereavement should you employ assisted dying. In fact, in some families, it's more complicated. It creates more problems. But this data hasn't seen the light of day, although we sent it to MPs and Lords. The people who are left out of this debate, remarkably, are the doctors. So what does doing such things do to doctors? Again, analysis of the data from multiple jurisdictions says 50% of doctors have feelings of discomfort about doing this, and 15 to 20% have long-lasting mental issues related to doing it. I didn't hear these words cross Kim Leadbeater's lips or Charlie Faulkner's lips. There's also the argument that actually if we introduce it, then the unassisted suicide rate, so people committing suicide, will drop. So we want to change the law because so many people are killing themselves with the diagnosis, and we know that having a diagnosis of, say, cancer, in the first 6 months you're at a much greater risk of suicide. We know that. It's a risk factor. But people are saying, so therefore, if we change the law, people can get this, we will cut down the unassisted suicide rate. Does that make sense? There was a study done in 10 American states where they looked at the suicide rates before and after the introduction of the law. And in that analysis, the unassisted suicide rate went up 6%. It went up 6%. And it went up 14% in women. Now, those are significant numbers, but when I told that to someone on the pro side, they just poo-pooed it. They didn't take it on board. The other argument that you hear is that if we change the law, then less people will travel to Switzerland. But that's not true, and do you know why I know that's true? Because around 60% of the people who have travelled to Switzerland would not qualify under the law that's being proposed. They're not in the last 6 months of their lives. So actually, when you change the law, or if you change the law, you don't create things equal, you create another level of inequity. I'm suffering intolerably. I have mental capacity, and I have less than 6 months to live. Kill me, please. Okay. Someone comes along and says, Article 14 of the Human Rights Act, you cannot discriminate against me because of this. I am suffering intolerably. I have capacity, but I have 5 or 10 years to live. On what basis can you tell me that I can't have this? And because you've crossed that line, you have even less leverage to answer with. Does that make sense? So the idea that if we change the law, less people will travel to Switzerland is absolutely not in line with the evidence at all. Final thing I want to say. I am interested in suffering. I believe God called me into this field because of suffering, and He wanted me to help suffering. And my team does an incredible job, and I am only a small part of that team. But the word suffering is not used at any point in the bill as a reason for assisted dying. You can read it yourself. And that is revealing. I want patients to have a comfortable and peaceful death. That's why I came into specialist palliative care. But I am not convinced from my experience and from reading the evidence that this will deal with the fundamental issue of suffering. That's before I get to the biblical text of the value of humanity. How much God loves us. The worth of our lives. That deep dignity which He bestows us with. I'm just going to leave it there, but hopefully that's given you something to think about. I'm happy to take any questions.
Yes, I was just going to say that. So, take a hand up if you'd like to ask a question. Yes.
Are there any circumstances where you would give somebody a help along the line?
I don't believe I need to, and I don't think that's happened in my career. Often what you're left with, I think people create a false choice sometimes. They say, I'm going to have to give this dose of medication in order to help the symptom. It'll have the unexpected side effect of killing them. That's called double effect ethically. Two things I would say about that. Number one, we're getting so good at controlling things that we really need to reach that binary point where you either kill someone or, it's a dimmer switch, it's not a flick switch. You can kind of go up and then, it's a bit too much, we'll come back down again.
But you could give extra drug to make people comfortable.
Absolutely, and the aim is to keep people comfortable. So I would not withhold drugs to not make someone comfortable.
I was in this position, my mother was very uncomfortable.
Yeah.
And I went to the nurse who was in a care home. I went to the nurse and I said, is it possible just to increase the dose?
Mm-hmm.
She nodded and did.
Yeah.
And my mother was made comfortable and survived for another 5 days.
Yeah. And that's I don't think for me that's not a contentious issue. If people need painkillers, they need painkillers and you give them. But you've got to dose them correctly, and if you do dose them correctly, it doesn't push them over the edge. That's the bottom line. That doesn't simply happen. In fact, if you give too much, say, of morphine, which is a terrible drug to try and kill people with, can I just say, you will make people worse, not better. They will become confused, they will hallucinate, they will run into problems. So with any drug, you still have to look at the benefits versus the risks, the effects versus the side effects. And I don't believe dying people deserve any less than people who aren't dying on that front. But you make an absolute point. The reason why probably there was pain in those kind of situations is because there's a lack of knowledge or competency or confidence from staff. And that's why part of my job is educating, to make sure people do not feel that they cannot give the drugs that are prescribed. We are a lot better now statistically than we were 20 years ago when I first came into this. We're a lot better at it. But we're doing it on a shoestring, and we need more. But I don't believe that razor edge that we think, well, if I give too much, they're going to fall off, or to do this, they're going to be in agony. That doesn't exist. That razor's edge doesn't exist. It's actually quite broad, and you can actually work with that. Within there. That's my experience of 25 years. Anyone's experience in this room is most likely, that's different from that, is most likely, statistically, to be due to the fact that they didn't get the care that they should have got, not that the medications didn't exist, or that the medications were done wrongly.
I think
you say that the doctors have been involved in this debate.
Yeah.
How do you hold your peers in your profession, your speciality, and also within the wider profession to see what their views are on this? Is there a consensus? Is it?
Yeah, so in palliative care, the consensus is no. About 80% say no, and that's because they have the similar experience that I do. Those who are for, there's many of them who are for it in principle, but no, practically it would be abused. Because we know that the basis of Kim Leadbeater's bill is threefold. It is that you have capacity, that you can accurately predict prognosis, and that you can prove that there's no coercion. Capacity, the law says, on the balance of probability. That's what the legislation says. You work on the balance of probability. So there's a loophole there. And I can give you cases where we've had to wrestle with our team. We know that prognostic, when trying to predict the last 6 months, is virtually impossible. And doctors are as wrong as often as they are right. And coercion is very, very difficult to predict. So for example, even with forced coercion, the Met Police Office in London was only able to take 5% of those coercive cases to a prosecution. Because we know those nuances within some of the complex cases that I deal with, and I've got at least 2 families on my ward at the moment who are fighting over a will and absolutely hate each other. You throw assisted dying into that, I mean, Kim Leadbeater and the teams would have you believe that it's all happy families. It simply is not, and it's naive to think that it is otherwise. So that's why I think 80% of palliative care doctors are against this. That's why most of care of the elderly are against this, because they deal with a lot of the deaths numbers-wise. But you will find no Royal College that is pro. The most you'll get is neutral, but in other countries that's the first step to changing the law. But none of them are pro. None of them are in favour. And in fact, the Royal College of Physicians has come out with a statement before the debate, Royal College of Psychiatrists, Royal College of Pathologists, because if you get killed by assisted dying, there is no stipulation in the bill that you have to go for a coroner's investigation. There is no coroner's report to work out the circumstances of that death. So because I know all of this, and because my colleagues in the field know all of this, and because those who deal with death most commonly in their job know this, we realise that there's too many loopholes. So that's a long answer to it.
No,
does that make sense?
That's very helpful, yeah.
Is that, sorry.
Yeah.
You just mentioned loopholes. So you think if the loopholes were closed, it would be okay then? In any circumstance?
I don't think you can get rid of the loopholes. And the reason I say that, if we don't believe in loopholes, or we don't believe in coercion, we don't believe coercion is an issue. 2 words I'll say about loopholes. Tax law. If you don't believe in coercion, I'll say advertising industry. So if we don't believe those things are going concerns, we will never close the loopholes, is the bottom line. It is too fine with the way families are with each other. I mean, I've just had a guy who's died who changed his name. We just realised after he died, after he delivered the death certificate, that he's changed his name because he'd done some heinous crimes in the past. Are going to die. There's all sorts, and I need the pro side to own that. Because on the one side, there are people who are vulnerable, who perhaps aren't getting the care they need, but want to die. But on the other side are these people who are more vulnerable, and the data coming out of Canada, when they've looked at some of the reports, have shown that it's more likely to be people who have mental health issues than people who are disabled, or who are poor, who are disadvantaged. So what's the law for? To protect the vulnerable? Yes, protect both. Well, kind of, but it's there to protect the most vulnerable. So so we need to find a way of dealing with this. But I don't think you can close the loopholes, is my bottom line. I don't have that faith in human nature. And biblically, that's probably true. We are depraved beyond what we know, and that's what the Bible tells us.
Mark, you must have patients, number of patients who are doing a resuscitate pulse.
Yeah.
So talk about the difference between assisted dying and doing not resuscitate.
Yeah, so what assisted dying is not, so assisted dying is the giving of drugs with the intention of killing a patient. What it is not is removing a treatment that is not working. Removing a treatment that is not working is good medicine. All right, does that make sense?
Yeah.
So it's not the same. The end result is you, put it bluntly, you have a patient who's died at the end of it. But the intention is entirely different. The intention of this one is to kill the patient. The intention of this one is to remove a burdensome treatment with the effective. Now that might sound like semantics, but it's actually quite different. In fact, it's very different. Now, returning to the point, I put that in the context of do not resuscitate. Do not resuscitate is about the value of one treatment. And that's if your heart stops, someone jumps and does compressions. That's what resuscitation is. It's not giving antibiotics. It's not stopping other treatments. It's that one treatment. Cardiopulmonary resuscitation. So if your heart stops, if your breathing stops, to make a decision to not have that instituted is a very sensible thing to do sometimes. And the reason why I say that is because of the evidence. If your heart stops when you're outside hospital, the chances of you recovering and leaving hospital are less than 4 or 5%. If you have a coexisting illness, like a cancer or a neurodebilitative disease, the chances of you surviving that are very, very limited. So all you're saying with the do not resuscitate is, first of all, will it work? You'd never be 100% sure, but probably not in those scenarios. And do we need to explain that to the patient? But does it exclude other treatments like antibiotics and all the other things they might need? No, it does not. That's nonsense. So do not resuscitate is only for one treatment, and it is a poor treatment. Let me be clear on that. If you look at films where they do they get them out of the swimming pool and they're doing this and all of that kind of stuff, 70% of the time in films it works. I can tell you as a registrar dealing with hospital patients, it wasn't until I got to my 15th and 20th that I realised that it was practically a waste of time most of the time because we never got people back. And actually if you do get them back, they're often very, very damaged. Very damaged. So it's about working out what the treatment is worth it. So not giving that treatment may be the best thing to do. Where we have fallen foul of this is thinking that do not resuscitate means you don't give everything. It's that one treatment. And I have to have this conversation most times with my patients and families. And when we have that conversation, they go, oh yeah, of course I wouldn't want that. And I'm saying, I'm not judging the quality of you. I'm judging the quality of the treatment. It's a rubbish treatment. And I would want you to dodge that bullet, please. And if you were my relative, I would say the same thing to you. So does that make sense, Donald? Yes,
that's good. One last question.
Yeah, it's perhaps similar to what you've just been talking about there. I think, sometimes try and prolong people's life when it's coming to a close.
Yeah.
For example, treating an infection with antibiotics, maybe that would be nature's way of them ending their life. Or even in care homes, treating people with antihypertensives, statins, etc. To improve the cardiovascular health, but the general health is very, very poor and the quality of life is poor. We don't seem to be able to make that decision about when we should stop treating and prolonging to make the quality of life really no better.
Mm-hmm. And I think that's right. And there's lots of nuances in with what you've said there. So if someone was dying in the next couple of weeks, I would stop all the blood pressure tablets, everything. There's no point. But there are some tablets, if I did stop, like if I stopped their antidepressants suddenly, they may start to get withdrawal. So I'd need to start thinking about, or if I stop their insulin, if I stop this, you need to be really measured in what you're going to do with these things. But what you're talking is about the decision of unnecessary prolonging life. And I will sometimes use antibiotics at the end of life to help symptoms. So if they've got an infection and they are hallucinating and confused, I can give them drugs for that, that's fine. But actually antibiotics might be if they've worked in the past, might be the quickest route to that. But what I'll say is that I will do this every 24 hours. I'm only using it for the symptoms. It will not change the outcome. This person is still going to die, but this is why we're doing it. But I think it's about being open about those conversations. But there's a whole body of literature about deprescribing at the end of life. And it's about confidence for many, many people. So often in a nursing home you don't have the confidence of the nurses who feel that they can just do that. Or the GP is so busy that they can't really look at the nuances of why, what do we do with the steroids, or what do we do with this, or what do we do with that. So I think there's still some debates and some teaching to be had, and I would love to be able to do that, but we are not given a resource to teach people how to do it. But I'm doing some teaching next week actually, and these are the very questions I'm going to be teaching the junior doctors about. Which drug would you stop at the end of life? And I've got a list of drugs, and then I get them to talk me through why. Some of them it's a straight no, some of them it's a, oh, hold on a minute. If we stop that, they'll get worse. Exactly. So come on, let's think about what we're going to do. But I think, yeah, generally it can be, it's badly done, but it's much better than it was done, is what I would say. And we have much better guidelines than we did 25 years ago when I first started in this. Not down to me, but just the knowledge is much better, but we need to keep going with that emphasis so that people feel equipped and confident to make those decisions. I think the other thing that's coming is that we've also got a population of patients and families who are very much more litigate-minded. And so there is this kind of defensiveness that people take and feel they can't perhaps have the conversations they need to have. So I think you've got a point. I think you're absolutely right. I think there's ways around that. But it needs to be funded, and we need to be able to give the education that we need to give and give people the confidence they need to give. Or go out, and sometimes I have to just go out to I go out to a nursing home and I'll go and say, no, what about this, and you say, don't you worry about that, this is where we're at, let's try this, let's try that. Worry about that, if we take that out we need to add this into the pump, just so they don't run into problems. So let's think about all of it. And so all of that is modelling and helping and confidence and, you know, making people not worry about things they don't need to worry about.
It's where you need the resources and time, isn't it? And
quite. Absolutely. But most of the time it's done really well, but the old people remember the bad examples where they don't. But yeah, I think it still happens.
Mark, thank you very much indeed. I thoroughly enjoyed that. We really liked it.